The NHS England guidance on weight loss injections currently kind of doesn't apply to most people. It applies to what I would class as the most at risk and the most at need, who wouldn't immediately qualify for it potentially. So the reason I say that, a lot of these patients who have very high BMIs, who are already known to be diabetic, in principle, they could have already had the treatment. Because if you're diabetic with a high BMI, one of the drugs you'd be trying to add in quite early is a weight loss injection. Because not only are they good at controlling your sugar level, but they're also very good at controlling your weight. The only thing is, because of their cost, probably, we kind of can't use them first line. So we have to use them sort of third, fourth line often, in the way that the prescribing guidance is set out nationally and even regionally. So it might just be that they haven't made their way to it, and they might not know that they're entitled to it either. So hopefully it would help some of them skip the queue, and essentially it would help them. And what you will find is some of those conditions are very obesity related. So sleep apnea is directly tied to your BMI, and there are other risk factors for it as well. And we know that your cholesterol level is relatively well linked to your BMI or your waist circumference. We know that heart disease has a correlation with cholesterol and obesity. So I think what they've done is they've looked at the things that are most likely to be related to someone's weight as the justification for prioritizing them. Now, the truth is, I think if your BMI is more than 40 and you have any one of those issues, nobody in the healthcare sector would have a problem with giving you that injection. It would be warranted. The reality is that would completely collapse the system. So, and I'm saying this very practically, given that we haven't been able to use this injection in any capacity in primary care for weight loss at the moment, most of them have been out of stock for as long as they've been around. So that's the viewpoint that you have to look at this through. So if they made it very easy to access, it just wouldn't be available. You would very quickly run out of stock. And so the question is, if you're going to give a very defined cohort with reliability, if you're going to give them this medication in a reliable fashion, who is most at need? So I completely understand why it's been done the way it has. If I was a patient and I didn't fit this criteria, which most people wouldn't, I would be incredibly frustrated. If I was a healthcare provider and I wanted to be able to give it in primary care, which by the way I am one of, I am frustrated.